There's a valve and yeah, that's right. We have that.
Yeah, good evening, Dr. Seth and Dr. Sharath, and I think it's a good way to start with the great case. And now I'm going to talk about delayed coronary obstruction. Let me share my slides. Okay. So we all know that coronary complication can happen during TAVI, and we know there are some traditional risk factors like patients with valve-in-valve procedures, patients who have low coronary heights, patients who have narrow sinuses. So we know that, and these risk factors we can identify, and we always try to protect. And these are some of our cases where we are protected with the stents and then done the TAVI. And very often we escape without any problem. And in fact, I have done more than about 10 or 15 cases like that, but none of them required any major stenting during or after the procedure. So this is what happens. Sometimes when we have very severe disease like this, one of our cases where we had a left main, which was actually taken off with a surprise in the sense CT didn't show, and we thought just do a check angiogram before TAVI, and we found this critical bifurcation lesion. And we had to do a left main stenting, both LAD and circumflex, and then we did the TAVI with the SAPIEN 3 valve. So all this is fine. When we know what we are going to, what is going to happen, we know we can predict, or we have significant disease we can treat. But what is delayed coronary obstruction, which is rather a little unusual and also very deadly. So I did look up literature. Obviously, I have not had any experience or seen any patient with the delayed coronary obstruction. So these are the two patients which I took it from the web, where this is one of the patients with valve-in-valve in a 70-year-old lady with a prior valve, Elan 23 millimeter valve, for which she was presented with a prosthetic valve degeneration, severe aortic regurgitation. If you look at the left coronary height was 7 millimeters, right coronary height was 13 millimeters. Obviously, valve-in-valve with the low coronary, definitely higher risk for coronary obstruction. For rightly, they did a protection. You can see they put a guide wire and they have doing it with a self-expanding valve. And what has happened is after the procedure, it looks quite good. The coronary flow is very good post-procedure. And you can see this is the pigtail aortogram after removing the guide catheter. So very often, even in myself, we see situations, we often try to be happy with this and we remove everything. And what happened to this patient is after 3 days, she was quite well for 3 days, and day 3 complained of chest pain followed by cardiac arrest in the ward, CPR, long CPR for about 50 minutes, transfer to cath lab, emergency angiogram. And we know the difficulties in engaging these coronaries, particularly in a self-expanding valve. And this is the flow in coronary. You see this very sluggish flow in the LAD, and there is some lesion in the left main. So obviously they attempt to stent the left main, and they stented the left main, and followed that the long CPR. The patient finally died after long CPR. Again, this tells us that how do we identify and how we could have salvaged this kind of a terrible loss. Similarly, another patient. This is an 80-year-old man with class 3 symptoms. Again, it's a valve-in-valve, previous AVR, Perimount, and again severe AR. So planned for valve-in-valve procedure. They obviously protect. You can see the coronaries are protected, and they see that there is some sluggish flow. So this partial obstruction. So they decide to stent the left main after the procedure. They have stented it, and looks good. Procedure looks good, and patient is discharged. Patient looks asymptomatic. 1 year post valve-in-valve, patient presents with unstable angina, and they find the right coronary occluded, and there is some lesion in the left main for which they did an FFR of 0.82, and they try to engage the right coronary, which they found it difficult, and finally they decided to send for CABG. So these cases, though very rare, can be deadly, and only rarely we have situations where patients have some time to send them for bypass. Very often it is a sudden event where we can't do anything about it. So, and we know that there is high in-hospital mortality when it occurs yearly. So we need to take it very seriously, particularly when we are now dealing with low-risk patients, because we know that surgery is a great option, and we do TAVI we have to be more careful about this complication. So prediction, prevention are particularly important. So what is the definition of delayed coronary obstruction? It is either obstruction of left main or ostial rights, RCA, after a patient has left after TAVI in a stable condition, is diagnosed by either angiogram or surgery or autopsy at the time of the event. So it is not solely related to the progression of pre-existing coronary disease or instant restenosis. So it's a new total occlusion of the LAD or the right coronary artery. So again, incidence, this was a large data from about 18 centers in 2005 and 16, where it was published in JACC in 2018, where they showed an incidence of 0.22%. And they found that the incidence was higher in valve-in-valve procedures compared to native TAVI. And similarly, the prevalence was high in the self-expanding valves compared to balloon expandable valves. So the timing of the presentation, what they found was in this study, most of the presentations were within the first 24 hours, about 47.4, and mostly within the first week after TAVI, and or after 60 days after TAVI. They didn't find any cases between the first week and the 60 days in their series.
Patients would die.
In one-third of the patients, patient presented with cardiac arrest, and about 25% presented with acute ST elevation MI. So who were presenting very early were likely to present with either an ST elevation MI or a cardiac arrest. Whereas when they present late, they come with either unstable angina, like the one who came 1 year later I had shown, had come with unstable angina. So what are the possible causes? Again, we are not sure. We have not, though there are known risk factors for coronary occlusion, acute coronary occlusion, we have seen these delayed obstruction even those patients who don't have those risk factors. So it is very difficult to obviously find the causes. So what are the possible causes? Possibly the depth of the valve implantation plays a role, and probably we need to learn more about whether there is a selection of valves. We know that self-expanding valves are slightly higher risk compared to balloon expandable in this obstruction. Whether this is very interesting. Whether the presence of thrombus, either in the sinus or within the valve itself, whether it can impact. So whether a valve thrombus can slowly progress and cause this kind of a problem, or whether anticoagulation does it make a difference? Again, I think we will have to know this. We are not sure whether anticoagulation will make a difference. So, but what do we do? How do we identify? Of course, patients with high risk anatomical features like what I mentioned should be protected, and these patients should be taken care. And obviously, after the TAVI, you have to closely look at the iontograms very carefully to see how the native valve is moved. Is it very close to the left main? Are we seeing any thrombus? Are we seeing any negative shadow? These are all important. Only about 2/3 of them have classical risk factors. So 1/3 of them do not have classical risk factors. So even if they don't have, we have to be very careful in the sense if they have any symptoms, unusual symptoms in the first week, we have to take it more seriously and consider doing a further evaluation like an iotogram, like a CT or maybe an angiogram. So the management, and most of them in the series, they found mostly it was 90%, more than 90% was left coronary artery, but some of them were right coronary artery. So obviously PCI was the most common management option. But again, the success of PCI was not great. About 50% of them actually died when they came with delayed coronary obstruction, died in the hospital. So it's a very, very poor outcome. So prevention. So as I mentioned, we can put in a wire if we have risk factors or keep a stent or a balloon. But again, what we do is either a chimney stenting, we put a stent, long stent from the left main throughout up to into the aorta. But we don't, again, this will be actually a life-saving for some patients, but we don't know what happens in long term. We don't have data. We don't know whether, how these stents work, whether stent thrombosis, all these we are not still sure. So we should have a high, we have to be very careful and have a low threshold to do a CT or iotogram whenever we have a doubt, whenever patients have symptoms. So what is the possible answer? How do we prevent it? Again, we know this elegant basilica technique. It has been shown to prevent delayed coronary obstruction after TAVI. This is actually a catheter-directed with the electrified guide wire. We lacerate the aortic leaflet before the TAVI, and with experienced hands, this procedure is they say it's quite simple. But this procedure should be done for those patients who are suspected to have high risk, or particularly in a situation like valve-in-valve procedures. But again, we don't know many other risk factors who will develop delayed coronary obstruction. We are not still sure. So the challenge is to identify which patients would really benefit from doing the Basilica procedure. So to conclude, delayed coronary obstruction is a very rare but associated with very high mortality, and appears to be more common with self-expanding valves and those patients with risk factors for acute coronary obstruction like low coronary heights and narrow sinuses. And we should have a low threshold for investigating these patients when they have some vague symptoms or any other suspicion. And we can always have if you put a wire and a stent, and if you have a doubt, always do a stenting when you have a doubt, so that we can save such patients. So, and we need to learn more about other risk factors so that we can plan Basilica, which is a very nice technique to prevent delayed coronary obstruction. Thank you.
Thank you. Are there any burning questions from anybody? Has any one of you experienced a delayed coronary obstruction?
Yeah. See, I had a patient.
And I would like Sushil Kodali to also have a comment on this, please. And
we had a patient, Ashok, who was TAVI was done with balloon expandable stent. Patient was discharged. Patient was staying in front of the lodge, and she came for a checkup. We did the echo, ECG, everything was perfect, and her coronaries were absolutely normal. And in the night, she had in the room she had a cardiac arrest, and when she was brought to the emergency, she was staying just across the hospital. She was dead. This can happen suddenly. Very difficult to predict. And we have analyzed all the things, and your result will be absolutely perfect. Probably delayed or thrombus formation, I do not know, but that's what happened.
Yeah, exactly. So we don't know the cause. Maybe it could be coronary obstruction, maybe
Correct.
it could be valve thrombus or anything else post-TAVI. But unless you have an autopsy or some other way to confirm, then we know that it is delayed coronary obstruction.
That is true.
There is some data about CT scans about 15 days post, and it showed actually a disturbingly high incidence of thrombus on the valve leaflets of the TAVR. And in fact, there were two studies in which they used one anticoagulant plus a NOAC plus an antithrombotic, plus an antiplatelet as a combination to try and prevent this. But somehow it didn't work because the bleeding incidence was so high. But definitely there seems to be one subset of patients with TAVR who have this problem, and related to either a leaflet thrombosis or some little bit of change in the way in which blood flows into the coronaries from the change in the sinuses.
It's usually the thrombus in the sinuses, but late deaths can be due to a number of reasons, unfortunately. So unless diagnosed, we won't know. But I think that was an elegant presentation. I still have a very big problem in trying to predict who. Obviously, the ones who've got low coronaries and have escaped occlusion at that time are the ones which we are most worried about. The low coronary heights who actually did not occlude at that time, and it's our practice to watch it for the next 15 minutes. But that is fine. You can watch it for 15 minutes, to watch it for 20 minutes. But for it to happen a few hours later or days later is obviously something one can't predict.
Does Sushil have any experience on this?
Sushil, is Sushil there? Because I would like Sushil's comments there.
Yeah, no, I'm here. Sorry,
okay, Sushil, go ahead.
Sangat, that was a wonderful overview. These are issues that are going to be going forward, especially as we treat lower risk patients. The question is this progression of disease? Is this related to the valve? Is this accelerated atherosclerosis? Is this thrombosis? You put stents, in the left main to protect. That's not benign. You can get restenosis. I think the reality is, especially if you put a long frame device across the coronary, access is going to be more difficult. Especially these patients present late with in the middle of the night with ST elevation. We have to learn tips and tricks for how to engage, how to treat, because it's going to be an issue not even in the left main, but progression of distal disease. one of the key things that has to happen in the next 5 years, in my mind, is there has to be ways to align the commissures of these valves, especially for long frame devices like core valve. Because there's that the commissures come up high. So if the valve is not oriented and those commissures are across the left main, I think you're going to be at higher risk for delayed coronary obstruction, but also access is going to be more difficult. So long frame devices, we're going to have a mechanism to align. And I think, the companies are going to have to figure that out, and new devices are going to have to figure that out. And that may also lead, aligned commissures may have better diastolic washout, less leaflet thrombosis, less coronary, better coronary flow. So these are things that, this is a limitation. And I think that's why, before you go to all low risk patients, I think these type of things, need to be taken into consideration.
And Sushil, Basilica, how often do you do Basilica, and mainly in which institution?
So, honestly, native coronaries, I've done it rarely. For valve and valve, we do it, in the small valves, mostly with the face sinuses. But I don't do it that often, to be honest. I probably do it half a dozen times. We did it last year.
I think we should continue on.
Yep, absolutely.
So I think I should go on to my presentation and share my slides, because and then I'll ask Dr. Ratha Srinivas to take it on further. So let me just see if I can get my slides up. Yeah, I think I can.